welcome to Medical Dialogues Journal Club, your daily dose of health and medical news. I am Dr. Nandita Mohan, and I'm going to talk about why cardiac surgeons are refusing to endorse the new ACC or AHA Guidelines 2021 for coronary artery bypass graft surgery in treating the coronary artery disease patients. Two organizations involving surgeons that has been assigned by the American College of Cardiology and the American Heart Association had been drafting guidelines process for 3 years now but declined to accept the final recommendations. Cardiovascular diseases are globally the major leading cause of death, taking an estimated 17.9 million lives each year. Coronary artery disease, the narrowing down of the coronary arteries, is the most common procedure that is being treated by coronary artery bypass graft surgery. Survival estimates among the CABG patients were 92% at 5 years, 77% at 10 years, 57% at 15, and 40% at 20 years. Several measures are put forth for proper management and to decrease the mortality rate. ACC AHA Guidelines 2021 is one such attempt in managing the coronary artery disease, unfortunately, which wasn't accepted by cardiac surgeons. The main purpose was to replace the existing 6 guidelines, and they raised concern in 3 main areas, starting with the downgrading of evidence issue of coronary artery bypass graft surgery in multi-vessel coronary artery disease patients, highlighting a serious problem in the guideline writing process that calls for ongoing discussion about how to achieve equitable representation by a multidisciplinary experts across specialties. Both surgical groups expressed their views. Respecting the right of the surgeons on the writing committee to remain as authors on these guidelines, they put forth their concerns of CABG and cardiac death rate management as well. We have here with us today Dr. P Yadava, CEO and Chief Cardiac Surgeon at the National Heart Institute, who will be sharing his valuable comments.
We're going to talk to you about the recently released ACC AHA guidelines for myocardial revascularization. Now, these guidelines were very much the felt need of the society because the previous guidelines were released in 2011, and for the last 10 years, there was no update. There was a lot of hue and cry, but before I go into the pithy issues, let me first acknowledge that 2 or 3 very good things about these guidelines is, number one, it is presented beautifully as standalone tranches, or what we call, or they call, knowledge chunks. So each subtopic is presented as a standalone tranche with its own reference section, and one can really do cross-referencing very easily. Secondly, it also brings to the fore the unequitable distribution of healthcare amongst diverse groups, especially the gender inequalities, geographical and racial inequalities, and even to some extent economic inequalities that creep into healthcare. So on those fronts, this guideline has done very well. However, it has raised, what shall I say, a hornet's nest, because STS, which is the Society of Thoracic Surgery, the premier institution of cardiovascular surgeons of America, and AATS, the second important association from USA, both did not endorse the guidelines and withdrew their nominee from the writing committee. The reason was that coronary artery bypass surgery, which was a class 1 indication in patients with multi-vessel disease, was downgraded to a very low 2B, that is maybe useful indication. And that became a sore point. Now, the 3 important things why this became a sore point and why coronary artery bypass surgery and PCI also, for that matter, got relegated to class 2B recommendation was, number one, there was over-reliance on the ischemia trial. Secondly, a generic use of the term multi-vessel disease was made in these guidelines. And thirdly, both PCI and CABG were clubbed together under a euphemism, revascularization. They were not looked at separately. Now, just kind of dissecting out the 3 points, ischemia trial, as you know, was a very, very important $100 million trial, which was basically launched to look at what is the initial mode of treatment which should be advised for coronary artery disease, in which they compared patients having moderate to severe ischemia undergoing guideline-directed medical therapy versus revascularization, and this revascularization included both CABG and PCI. However, this and the ischemia trial came out that both were equivalent and revascularization could not be demonstrated to be superior to medical treatment. But then ischemia trial was not powered to look for mortality and was not powered to look at incidence of spontaneous MI. Also, the ischemia trial, the primary endpoints were changed 5 years down the line, and the follow-up was just 3 years, 3.2 years to be precise. And we know that in coronary artery bypass surgery, at least, it has been shown in the STITCH trial, it has been shown in the FREEDOM trial, that the survival curves diverge only after 5 years. So at 3 years, if you start making a comparison, things may not show up. So because of number of other issues with ischemia trial, it was felt that the over-reliance of the guideline writing committee on the ischemia trial was not justified. Second thing was the generic use of multivessel disease as a term. Now, the guidelines did not differentiate between a multivessel disease, which involved the proximal segments of the coronary tree and therefore the huge amount of myocardium, including proximal LAD, versus a multivessel disease where the involvement of the stenosis was downstream after major branches had taken off. So, this was not kind of comparing apples to apples and oranges to oranges. And it was felt that a specific sub-study of patients with proximal LAD stenosis and of proximal involvement of circumflex should have been carried out instead of having a generic use of the term multivessel disease. And it has been shown over last 20 years that proximal LAD is an altogether different ballgame. Use of meta-analysis is a very famous meta-analysis. A number of other studies have shown that CABG has a survival advantage in proximal LAD. But if we include things like ischemia trial, where CABG was done in barely one third or thereabouts patients. Now, even if multivessel disease with diabetics, PCI is offered or medical treatment is offered, CABG is not done in the right numbers, then CABG is not likely to show its class and its benefits. And the third thing was clubbing PCI and CABG together under the term revascularization. In fact, a number of meta-analyses were quoted by the guidelines as supporting the fact that medical treatment did equally well as the revascularization. But in these trials, out of 14 trials, 5 did not include a single patient of CABG. And in the majority others, CABG was done in a very small 15 to 20% minuscule number of patients. Balance 80% were angioplasty or stenting. Therefore, the two cannot be equated. Using revascularization as a surrogate term for CABG is not correct. And even if you look at the premise or the basic fundamental premise on which it works, angioplasty treats focal flow-limiting lesions. But bypass surgery bypasses the entire proximal segment of the coronary tree. And we know there are a lot of other moderate stenosis which may generate spontaneous myocardial infarction. Angioplasty do not attend to them, do not address them, but CABG takes care of them. So there is a mechanistic basis. CABG prevents long-term spontaneous myocardial infarction. And through this prevention of spontaneous myocardial infarction, it gives a survival advantage. And that's why in a recent paper, it has been suggested that CABG is not just a technique of myocardial revascularization, it's a technique for myocardial preservation. So because of these multiple reasons, the European Society has protested. In fact, the European Associations of Cardiothoracic Surgery and the European Society of Cardiology Guidelines of 2019 have given class 1 indication for CABG in multivessel disease with proximal LAD. So they have protested. The Latin American Association of Cardiovascular and Endovascular Surgeons, the LACES, has again protested. And the Indian Association of Thoracic and Cardiovascular Surgeons constituted a committee which has published a document, which is a consensus document in Indian Journal of Thoracic Cardiovascular Surgery, which has protested these guidelines besides the American associations. So these are important lacunae, but apart from that, the guideline is a very welcome development, and a lot of recommendations for primary PCI, for non-ST elevation myocardial infarction, and some technical details are also welcome. So ladies and gentlemen, with that, please go through these guidelines. They are very, very updated and important for our day-to-day clinical practice. Thank you very much.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.